State Board of Pharmacy meeting, July 28th. We'll start roll call. We'll start over here with Albert.
Albert Wall, professional member.
Ricardo Sanchez, public member.
Amy Gutierrez, professional member.
Debbie Field, professional member.
Lavanza Butler, professional member.
Ramon Castablanc, public member.
Victor Law, professional member.
Greg Lippy, public member.
Okay, we're going to go into closed session. So we're going to be moving into the Enforcement Committee, then the Communication and Public Ed, and then we will be doing the Executive Officer's Report and the Org Development Committee later on. So moving on to the Enforcement Committee report, which is on your agenda as item 18. So we're moving it up. So per the packet, the first item is enforcement matters and discussion and consideration of the UC San Diego's pilot program to permit patients to access medications from automated storage devices not immediately adjacent to a pharmacy, including requests for modifications to the study parameters. At our April 2015 board meeting, the board approved an 18-month pilot study under the auspices of UCSD School of Pharmacy involving the use of an automated storage device for prescription med at Sharp Hospital in San Diego, where their families and where employees or their families could opt in to pick up their outpatient medications from the storage device. Consultation would be provided by a telephone before the medication could be dispensed to a patient for the initial dose, and the technology has software to allow that to happen. The study was planned to start in June or July 2015. However, at the September 2015 Board Enforcement Committee meeting, Dr. Hirsch, who is our main contact for the study, anticipated the pilot study would not begin until December because they needed some additional time to set up the automated device. At the December 2015 Enforcement Committee meeting, they stated that they would launch the device, enroll patient, and refine data collection tools. And at the March 2nd, 2016 Enforcement Committee, Dr. Hirsch reported the study had actually launched in January of 2016, and 120 patients had enrolled to use the automated device. The committee had recommended that the board ask UCSD for the number of employees and the work hours of those who utilize the device. So at the April 28th board meeting, the board approved the recommendation. So at the committee meeting that was held, recent committee meeting, Dr. Hirsch delivered a presentation on the progress of the implementation of this pilot program and reported that the launch did occur on January 20, and because of the kiosk was originally located near a fire exit, they actually had to move the location of the device to an alcove on the first floor lobby on May 28, 2016. The kiosk still has 24-hour video surveillance and on-site monitoring. From the statistics that we were provided, there have been 534 total pickups through the date of the meeting, and 334 of those pickups had been during normal business hours. So it's being used while the pharmacy's open as well. 191 of these were identified as new prescriptions, 99 were refills, and 234 were for OTC medications. We actually had a discussion about that on the large number of OTC medications, so it's basically servicing as a vending type machine for over-the-counter. Dr. Hirsch had requested an extension of the study because she said they needed to average 140 prescriptions pickups per month to reach the target of 820, but they're only using 80 pickups per month. So they're requesting an extension through December 2016 and proposing a report back to the board in March 2017. So the committee, there's a copy of Dr. Hirsch's presentations that the committee heard, and that is in attachment 1. The committee recommendations are to allow UCSD to collect the data through the first quarter of 2000, or through the first quarter of 2017, and then report the findings back at the May 2017 board meeting. and also allow UCSD to continue operating the kiosk until a decision is made at the April-May 2017 board meeting. UCSD was concerned, and Sharps, that they're going to be putting this device in. They're going to present us back with the data, but in the interim, what are they going to do with operating the device? So they wanted to have the ability to still continue to operate while they were tabulating the data and presenting it to the board.
If you calculate 80 prescriptions a month, that means it's less than 3 prescriptions a day to a pickup, and 1/3 of those are over the counters. So the actual prescription fill is like maybe 2 a day. So I just kind of question the usefulness of such a study. So,
You know,
Well, the other thing is, this was supposed to be for a short period of time, and now it's turned into a couple of years with no real definite end, given that it's not apparently working. So what's the thinking on that?
I think there was some delays in implementation that were beyond their control. I mean, the location had to be removed, so they really didn't get going until January of this year, by the time they actually got, January 20th, by the time they got the machine operational.
did they say why, what they were going to do to try to get the usage up?
I think they're advertising and word of mouth. I mean, it's like when you open a new store, you've got to wait for the business to ramp up. So I
I was just curious if,
go ahead, Jenny.
From what I remember during the meeting, I think they were concerned about the low participation rate, and they were considering various options to increase participation. That was the reason they were going to have to extend the study, because they didn't have the volume of participants, so.
no,
they're
I
very aware
understand
of
that.
it.
I was just wondering if they had a plan how to get there, since they're asking us to extend it.
Not one that I specifically.
Well, so is there like a definite end date to this? Because if it keeps flopping along like this, then it doesn't seem
Well,
like
right
it's
now, the
working.
definite end date is they're going to collect data through the first quarter of 2017.
Oh, yeah.
So that'd be through March 31st. And then they would provide the board with the data feedback April or May. And then at that point, the board would make a decision
Okay, and
on whether to extend the pilot or what we're going to do. Now, in the interim, there also is some legislation that we're sponsoring on automated dispensing devices that would include this cabinet as well.
It would require that it be registered with us, so that we would know what pharmacy was responsible for it.
But our legislation does not expand the conditions under which you can use it. So for purposes of this regulation, you had to grant a waiver to use it in this specific setting under these conditions.
But I will tell you, the board is receiving, I received an inquiry earlier this week from someone that's interested in establishing the same kind of device in additional places where they wanted to be able to come talk to the board and become part of a pilot too.
I mean, I'm definitely in favor of going ahead and giving them a little bit more time. I mean, this is kind of the future of maybe where we might go, and so we have one, seems like fairly well-controlled one, although a little bit stretched out. I think it's still worth the risk, because it is one, we're keeping our eye on it, they've been very communicative.
right, I just want to make sure as much as I can that it's a safe future.
Yeah.
And that,
Good call.
As we get more of these machines out there, we really need to get a handle on it.
Yeah, and we'll talk about the statutory authority as item F on the agenda, so it's coming up. So there's a committee recommendation. Is there any other board questions or comments before we open it up for public comment? Public comment?
Steve Gray from Kaiser Permanente. Pardon for the fact that I took off my coat, but I ran for those of you in the room who know about it, I ran to get my luggage out of the car before I forgot it. Okay, never mind.
A little reminiscent, huh?
And now you have it in the middle of the aisle, so everybody sees it.
There you go. Kaiser Permanente wants you to encourage to also follow the committee recommendation and let them finish the study. The reality is, and we have a lot of experience with pilot studies, the reality is that, yes, this may not be the definitive pilot study, but what we learn from this study may be that it's not the right way to set up the pilot for this. Maybe the location was wrong, the situation was wrong, and that is a valuable learning in and of itself. But we encourage you to go forward. As the UCSD people has indicated, and the vendors that sell these are already readily used in many states, and allegedly without any problems, both for new and refill prescriptions. So I do think it's invaluable to proceed along these lines. It may take another follow-up pilot to get the data that you're comfortable with, but I would encourage you to let this one play out so that we learn, if nothing else, we learn how to better to set up a pilot study. Thank you.
Any other public comment? Good morning.
My name is Karen Nishi. I'm a pharmacist, and I've been very involved with automation. I'm not involved with this pilot project, and so I'm speaking as a pharmacist who likes automation, and I think it's important that we do have pilot studies. It's the first one here in this state. UCSD has worked hard, it sounds like, to meet all your questions, and sometimes automation or pilot studies aren't like the best or the smoothest. But if we never try it, we'll never know. So at this point, you have control of that study. You're working with the people, it sounds like. So let's just move it forward. And then on the other agenda item, it sounds like you still want to have some control by overseeing these boxes or automation type systems. So let's go ahead, let it play out, and see how it goes. So thank you for participating and letting it happen, because I know how those first pilots of automation can be. Thank you.
Thank you. Now, we've also got a pharmacy school involved. We've got a large health system. So we've got some very good participants that are doing this pilot that can provide us. I think, Ramon, you reviewed their protocol as well before it was established, so. All right, so the committee recommendation is to continue the study per the parameters that we reviewed. All those in favor? Okay, unanimous. Okay, item B, discussion and consideration of the proposed regulation relating to reconciliation and inventory reports of controlled substances. So it's to add Title 16 California Code of Regulations, Section 1715.65. So as you recall, at the July 2014 board meeting, the board approved initiation of a rulemaking to establish inventory requirements for controlled drugs for pharmacies and clinics. The initial regulation that we reviewed, or the language, would have required perpetual inventory of all federal Schedule II drugs with a physical count every 90 days. And in addition, the board would establish a list of one of several additional controlled substances in Schedules 3 through 5 that are reported as frequently stolen. So it would be a revolving list in terms of the initial language. And these are frequently stolen as reports to the board and or the DEA. The regulation was released for the required 45-day public comment, and that occurred between October 16th and November 30th, 2015. At the February 2016 board meeting, the board referred the regulation back to the Enforcement Committee for review and consideration due to the multitude of comments that we received from the various pharmacies and stakeholders. At the committee meeting that we held at the Enforcement Committee, in anticipation and after review of all the comments, Ms. Harold and I developed a new draft of the regulation, which we presented to the committee. And this new draft would require a quarterly inventory and reconciliation, not just an inventory. So it's not just counting the drugs, it's also taking into account your ins and outs so that you make sure what the inventory is. A copy of it actually is in attachment 2 of your packet, and if you look, it's the one that's entitled Proposed New Draft 525-2016. So there's 2 different regulations on there, the original one and then the new one that the committee reviewed.
Binder that we left yesterday in the back.
Okay, it's also in the binder, Jenny says, that was provided to the board members. For drugs stored in and we had a healthy discussion at the committee meeting from stakeholders that involved automation drug devices as well as hospitals that were impacted. For drugs stored in automated delivery devices, the feeling is that the system actually does track your medications that are stored. So in this regulation, the pharmacist in charge would be responsible in part for ensuring that the drugs are accounted for and the device is secure. The draft removes any requirement for the pharmacy to count the physical inventory of each automated dispensing device because of the active ongoing reconciliation process. There was also a 7-minute news report that we reviewed from Colorado, where the Colorado Department of Public Health is actually, there's a news agency that actually requested under Freedom of Information Act data from the Public Health Department on all the controlled substance diversion reports that were received and from hospitals. And they've actually posted a query on their website where you could look up your hospital and see what diversion was occurring in that hospital or reported diversion. Comments received by the board and copies of the 2 most recent proposed drafts are provided in attachment 2. So you'll see the original language, the comments we received, as well as the new revised language. So if you see that, it's under 17.5.65. So in this language, every pharmacy and every clinic that's licensed under 4180 or 4190 shall perform periodic inventory and inventory reconciliation functions to detect and prevent the loss of controlled substance. And again, this is to try to see that we can identify these losses earlier before they come into the thousands of tablets. And that we've seen in some of the reports that we're receiving on losses that total to quite a bit. And I don't think that there's anything we're asking here that some of the chain drugstores aren't already doing. In fact, they're probably doing it more often than every quarter for the Schedule 2. The pharmacist in charge of a pharmacy or consultant pharmacist for a clinic shall review all inventory and inventory reconciliation reports taken and establish and maintain secure methods for prevent losses of controlled drugs. Written policies and procedures shall be developed for performing the inventory reconciliation reports required by this section. Item C, a pharmacy or clinic shall compile an inventory reconciliation report of all Schedule II controlled substances at least every 3 months. This compilation shall require A, a physical count, not an estimate, of all the Schedule II controlled substances. The biennial inventory of controlled substances required by federal law may serve as one of the mandated inventories under this section in the year where the federal biennial inventory is performed, provided that it was taken no more than 3 months from the last inventory required by this section. B, a review of all acquisitions and dispositions of Schedule II controlled substances since the last inventory reconciliation report. C, comparison of the physical count and the acquisitions and dispositions to determine if there's any variances. D, all records used to compile each reconciliation shall be maintained in the pharmacy or clinic for at least 3 years in a readily retrievable form. Item D, losses shall be identified in writing and reported to the board when appropriate to the DEA. Likely causes of overages shall be identified in writing and incorporated into the inventory reconciliation report. Item E, the inventory reconciliation report shall be dated and signed by the individual performing the inventory and countersigned by the PIC and be readily retrievable for 3 years. Item F, a new PIC of a pharmacy shall complete an inventory within 30 days of becoming PIC as identified in subdivision C. Whenever possible, an outgoing PIC should complete an inventory as required in subdivision C. And we put in whenever possible because if a PIC is leaving, I don't know how you're going to force them to do that. I mean, whenever possible. G, for inpatient hospital pharmacies, and here's where you're going to see the big difference is in the hospitals. For inpatient hospital pharmacies, a separate inventory reconciliation report should be required for Schedule II controlled substances that are stored within the pharmacy and for each pharmacy satellite location. So the inventory is restricted only to the physical count and the reconciliation to the pharmacies. H, the PIC of an inpatient hospital pharmacy or of a pharmacy servicing on-site or off-site automated drug delivery systems, so that could be in the hospital or it could be off-site. A, all controlled substances added to an automated drug delivery system are accounted for. B, access to the automated drug delivery systems is limited to authorized facility personnel. That's typically done through creating passwords or BioID, so there's a user database that's maintained. C, an ongoing evaluation of discrepancies or unusual access associated with controlled substances is performed. D, confirmed losses of controlled substances are reported to the board. E, a pharmacy or clinic identifying losses of controlled substances but unable to identify the cause within 30 days shall take additional steps to identify the origin of the losses and improve security of controlled substance access to prevent losses. So originally, the original language had items such as you're going to install a security camera, and we thought this would be better to leave it up to keep that very vague, because you really don't know what the cause is, and it depends on the situation and what actions are appropriate in order to allow the pharmacy to identify the best security tactic to take. So the committee is recommending that the board withdraw the old rulemaking and initiate a new rulemaking using the revised proposed language that we just reviewed that's dated May 25th, 2016. Board comments?
I like the changes myself.
Well, could I ask a few questions then?
Yes.
So you decided that cameras are not always a good idea and not to specify that?
It depends on the location. I mean, it depends on the situation and where the loss is. That's why we said on there, they shall take additional steps. So it depends on what the additional steps may be. It depends on the situation and what happened. If you're overseeing it, you should have the ability to figure that out.
All right. It's hard for me to understand why a camera wouldn't help.
Depends if you can have a camera posted, but if you're not watching it and if you're not recording it, you're not going to get much value
Well,
out
sure,
of
I
the
mean,
camera.
you'd be recording or something like that, so you could go
Yeah.
back later and see.
Then how long do you keep the tape? And, I mean, there's a lot of issues with that, and it may not be the best solution for that particular incident. So it just depends on
So we'll,
what
on a
happened.
case-by-case basis, decide if they made a good faith effort to
Or
remedy the problem.
Well, it's depending on the issue, what
Well, that's what
occurred.
I mean.
How did the loss happen? What would have helped? And really, the pharmacy or the PIC should have the ability, if they're reporting losses, they're going to be incentivized to find a way to cut those losses.
Okay. And now how does this affect all the automatic dispensing machines? The ones that are out there, you know, that we're going to start counting soon, but we haven't started to count yet. Because there's a whole other place where there's drugs, right? Besides pharmacies and hospitals, there's these automatic dispensing machines that are out in the, stratosphere somewhere.
Yeah. This is,
Internal perpetual records of the machines.
We don't even know where they are.
well, right now, I don't think now, correct me if I'm wrong, Jeannie, but I don't think they're not really required, they can't have them right now if they're not, off-site storage devices like this, under the law, we have to pass this new reg to be able to do this?
What we're doing is directing that they do it, but the pharmacy owns the drugs. When it's in a skilled nursing facility, in a machine in a skilled nursing facility, the pharmacy owns the drugs. So the inventory requirement will require that they do that, I believe, because where the drugs are kept.
So if you look at item H, it says the PIC of an inpatient hospital pharmacy or of a pharmacy servicing on-site or off-site shall ensure. So they're going to have the same requirements to make sure that they're doing that check. And if there's a loss. Yes. Well, what they do typically is you use a concept called blind count, so that if I'm a nurse and I'm going up there, I use my BioID, the machine opens up, and it asks you how many tablets are in there. And if I count and I say there's 8, and the machine registers, I should have said 10, that creates a discrepancy. So somebody knows. It doesn't ask you, it shouldn't, at least if you're programming it appropriately, it doesn't say, hey, are there 10 tablets in there? Because that's really easy to just say yes. It says how many tablets are there. That way you actually at least catch. Yes.
Required to count them. This way, somebody can't just say, yes, that's how many there are in there. They have
Correct.
So we're saying that every single off-site automatic drug delivery system in California is either under the control of an inpatient hospital pharmacy or a pharmacy?
If it's provided by a pharmacy, if it's supplied by a pharmacy, my understanding is it is.
There could be some physicians that own their own dispensing machines, those would be excluded, but it has to be the physician's-only drug stock. And there may be some other ones out there that we're not thinking about, but the ones within our purview
But
are,
we don't have purview under the physician's.
right, we don't have any control over those.
And
I
there's
was
al- there's
answering the
also
other-
fire departments, too, that probably
Let's not
have
even
them.
go there.
Well, I'll be interested
interfere
when,
with the
because we do intend to catch up with all these machines, identify them where they are.
That's
So-
the-
We don't even know, we don't know where they are, and we don't know what kind of
Exactly,
losses are coming out of
exactly.
them. So
We don't
this
know
is
where
our
they
first
are, how
step
many
in.
there are.
Yeah.
It could be hundreds, so we want to be sure, as part of our ongoing mission, to identify those machines, make sure
Well, that's
they're-
actually item F. We're going to talk
Okay.
about that, the registration of the devices.
And are they supposed to send in the report every 3 months, or only when they find there are discrepancies?
They report losses,
Only the losses,
same as
or,
a requirement, if it's a controlled drug, they're required to report it.
and if they have 20 tablets over,
Otherwise,
5
they just-
tablets short,
Yep,
they will
and
send
we're
it
getting
in?
reports from hospitals now for when they lose one tablet, and what that shows is they're counting down to the one tablet level. It's protecting
Right.
themselves.
So now we have 6,000 pharmacies, you're going to get 6,000 reports every 3 months?
Yeah, we have a
You
new
have enough
staff
staff to-
person.
to-
We're
to
putting
staff
in a
to-
budget change proposal to add someone to kind of track this, right? Isn't that one of the things for the 106 reports?
One of the things that if you read that Colorado, one of the things that struck me is that if a pharmacy's reporting regular 1 or 2 losses, it's probably, I mean, things are going to happen. Tablets are going to drop. I mean, it's just part of the process. It's those that aren't reporting or reporting huge losses that you really got to watch out for. So that's, I mean, I would think we would focus on those.
Right, and then the other thing that'll prevent is cases where suddenly you've lost 95,000 pills and you hadn't done a count. The goal is to do them more frequently so that you can identify, well, 93, okay.
Any other board discussion before we open it up for public comment? A public comment? Morning. Is it still morning? Yeah.
This seems like afternoon.
Good morning. I'm Jim Santa with Consana's Pharmacy, and so I'm an independent long-term care pharmacy, and I'm trying to get my head around, I'm trying to just be really honest and say I'm trying to get my head around how I'm going to do some reconciliation every 3 months as far as the labor that I'm going to have to put into it, and as far as even tackle boxes. I've got tackle boxes out there, so I'm trying to figure out how I'm going to do that also. And I'm asking the board, have you, with all due respect, have you gone to a long-term care pharmacy and evaluated the amount of time it may take and the amount of labor that it may take? Certainly, we want to protect the public, and we want to do everything we can to alleviate diversion, and that is very important. But as a small business owner, I'm trying to get my head wrapped around how I might accomplish this on a
Let me
quarterly
ask you,
basis.
you understand this is only for Schedule II drugs?
Correct.
So for Schedule II drugs, do you have a software program where you're tracking remote inventory for those machines?
We do have remote inventory on machines. The automated dispensing cabinets, actually, that's pretty easy because they do track what goes out and what comes in. And so that's pretty easy. But the tackle boxes would be, I'd have to establish some sort of a manual process. And then on that quarterly basis, I'm trying to think, do I pull them all out of the nursing homes and do the counts and they don't have anything? There's going to be some averages, or this is what I should have. I'm trying to get my head around how I would do that. I just want the board to know that I'm really trying to understand how I'm going to make this happen.
Like how many tackle boxes, or maybe a better way is what % of your long-term care clients have tackle boxes versus machines?
For Schedule II?
Yeah.
I have 45 skilled facilities, and I have about 9 automated dispensing cabinets. So the rest do have tackle boxes out there.
And right now, are you inventorying them, like how often?
We keep a running inventory on every controlled C2 substance that we send out. So when the boxes, if there's no usage out of a tackle box, we call them in on a weekly or bi-weekly basis to make sure that there's been nothing taken out of that tackle box. And so we keep an inventory in that way. But most of the tackle boxes,
Does that fit? Or, I
Aren't you
think-
doing a reconciliation then? You're getting
We
records
do a
back,
running
right?
inventory.
And you're saying like every couple of weeks, so we're saying every 90 days, it sounds like,
Yeah.
Well, every couple of weeks, I pull the boxes back in if they haven't been used. Most of the boxes, maybe I'm not being clear. So we send a tackle box out to a skilled facility. Usually, there's something that's being pulled out of that tackle box every day. And so I'm seeing them every day coming back in. And we keep a running inventory. In other words, this is what we should have on hand, and this is what we do have on hand. But the reconciliation part is going back this 3 months, trying to make it balance. And so when that day comes, if today is the day
but you
that
don't
I...
have to do it the same day for every single tackle box. Like, it's not like
No.
tackle box and my whole system has to be done
Right.
on the 28th.
That's true.
That's what the board's requesting? Is that what you're asking me?
No, I'm saying you don't have to do it all, like every box on the same day. So,
Once every 3 months.
yeah, just, so every box could have its own 3-month clock.
I see. So we could do,
You could just build it into what I think you're doing.
okay.
Don't
Do you ever see, do you ever see the tackle boxes back?
Oh, yeah.
Okay, then you do the reconciliation report at that point.
Like, so once a quarter, when that box comes back, you reconcile it.
I issued 20 morphine. Here's the 20 patients that got it. I have no losses. Move
But the
forward.
reconciliation would be, let's say, for a 3-month period. So we'd have to gather all the purchases.
But don't you already
Correct.
have that on your running inventory?
We keep a running inventory in the pharmacy. That's correct. Everything that we've purchased and everything that we've dispensed that's
But you-
balanced. But what I'm...
You say, I got a bottle of morphine,
Mhm.
but you don't have, are you worried about, you don't have like the invoice right there, or?
Correct. Because I think what you're asking for is over a 3-month period, you want to see that I purchased 2,800 hydrocodone.
Right. Dispense
On
2,000.
a running inventory,
And you still have 80 left.
I purchased a bottle of 500. Here's the bottle of 500. And then we dispense out of that. And then when we buy another bottle of 500, we do that. We don't, there's not a reconciliation. In other words, you could go back that 3 months, but not totals. Does,
Keep a record that I've dispensed this much for each of your nursing homes so that you can tell what your transfers were to that nursing home?
we'd have to pull that out of our framework system, the pharmacy system. So in other words, I would have to put in dates for each drug that says we dispense this many, then go to our wholesaler that says we purchase this many, or I would have to change the way I'm doing my running inventory, because running inventory,
You're making it maybe more
Yeah.
difficult,
How do
because I think what we're picturing, and you're the expert, so tell me if I'm picturing it wrong, is that you have this tackle box, and you say, okay, here's my tackle box, I start out with 0, okay, I put in 10 pills, on July 1st, I had to put in, 10 morphine on July 1st, I had to restock that with 10, maybe a week later, I had to stock with another 10 a week later. I don't think we're asking you to go back necessarily to that 100 bottle where it came out of in each case. I think we're just saying, you put in 30, how many came out? It says you should have 2 left. I have 2 left.
okay.
And you can do it at least every 30, you can do it every week if you want. It's just at least once every 3 months.
You could reconcile it every time it comes in your
So
meeting.
what are you doing right now to identify if you've lost drug? Right now, you
Bottle of
must have a
500
process.
comes in. Everything that we put in a tackle box or dispense is minus. It's like a checkbook. And then every day, we count the C2 drugs that are on the shelf. We do that every day.
In the
And-
tackle. So right now, how do you know that
Well, the
you don't have?
tackle boxes are
how do you know
out
you-
here.
So how do you know when you are supplying drugs, you're a pharmacy, you're supplying drugs to a tackle box.
Mm-hmm.
How do you know that there hasn't been a loss of a tablet there right now?
We only know that when the tackle box comes back.
You reconcile it then?
We reconcile it then.
So you're fine. As long as you're doing that once every 3 months, you're fine.
So if I'm hearing this clear, I just want to make sure, I don't have to go back and say I purchased 78,300 drugs. As long as I say, if I run a running inventory on a daily basis and I know I'm missing 5 tablets, then
And you're doing a daily
I'm
reconciliation?
doing a daily and you're okay with that?
Okay, so here's the language. It says at least every 3 months. So you could do it every week,
Or every day.
and you can meet it. So if every time that tackle box comes in, as long as it hasn't been outside for 4 months, then you're good.
What we're trying to avoid is these cases where you're just doing a biannual inventory every 2 years, and then when you do it, you realize, oh no, I've got drugs leaking out, and I've got 93,000 tablets missing,
I
because
know at the
nobody's
end of the
looked at
day.
it.
Yeah, I know at the end of the day if anything is missing.
Fine then.
I think you don't have to change anything.
And then just for information to the board, because I also count everything that comes in, I do have evidence and proof and have addressed with the manufacturers that I've, so far in the last 4 months, I think it's been, I've had 3 or 4 bottles that have been short by anywhere from 5 to 12 tablets.
I've actually, my pharmacies have the same problem with
Yeah.
hydrocodone.
So we count everything we count the hydrocodones that come in. That's the big ones. The other ones that are in the bottles of 100, we believe them, but I think they're loaded by
You're
weight.
right. It's
And-
a specific generic manufacturer.
Correct.
Yep.
Yeah. Okay, so I think I'm clear
You may
on
want to
that.
report it to the FDA, because that's what we did.
Yes, we did also, and reported to the drug company, and they kind of blew us off. That's why we went to the FDA, so,
Get
okay.
enough reports from all of us, I think they'll do something.
I'm sorry, what?
If they get enough reports, the FDA, from various customers, I think they'll do something, or clients.
I think I'm clear then. So really, a daily running inventory like I'm doing is satisfying that reconciliation.
I would think so, yeah.
Okay.
That's our intent. We're not trying to
As
make
long
it
as you
harder.
count the box when it comes in.
Counting them every day, so.
Comes in more often than once every 3 months.
I hope that helped.
That helped. Thank you.
Good morning, Ken.
My name is Ken Schell. I'm currently the Director of Pharmacy at Sharp Grossmont Hospital in San Diego, and also a past board member. And I just
And
wanted
not
to...
only board member, but president.
Oh, well, I'll never tell that secret stays in this room. I just wanted to speak in support of the regulation. This is a far superior regulation than what was previously happening, and we do reconciliations on a daily and a monthly basis. And so, as the gentleman previously alluded to, we do know when there's something missing, and we have daily reconciliations with the nursing staff to make sure that we identify it. And if something goes missing, then we do report. But I'd say that the missing doses are very small. But the regulation itself is very clear. It really helped the pharmacies. And I can't speak for the locations that are outside of hospital. I've been director at 2 pharmacies now, hospital pharmacies. This is incredible for me. This would make things very clear for my narcotics people so they understand and know what to do. Also for our buyers so they know what to do as well. So if we see this disparity of what was purchased for what was used, I'll know almost daily if that's going on as opposed to monthly, and this makes it very clear. So thank you very much. Really appreciate it.
Thanks, Ken. Any other public comment? Janice, are you coming up? All right. Our supervising inspector, Janice Dang.
She's also an Uber driver,
Is she? Is that your new title?
just for us.
Oh, that's right, she was.
trades.
Did you get money from him, though?
Oh, no, I didn't even get a tip.
We offer you the dinner.
Okay, Janice Dang, Supervising
you did
Inspector. I just want to address Ramon's questions regarding the long-term care automated dispensing devices. Under the Health and Safety Code 1261.6, the facilities are required to have policies and procedures that address security and accountability of the drugs. And in addition, on a monthly basis, a pharmacist is supposed to review the security and the accountability of the drugs as well. And so what they usually do is they generate these reports to reconcile the counts.
Thanks,
Well,
Janice.
Well, as long as I'm bringing up all kinds of things. How about ambulances and the drugs that they carry? Well,
Depends on who's supplying them. So you need to look at the source, because a lot of the ambulances are now utilizing physicians' DEA numbers, so that wouldn't be under our purview.
would not.
No.
But there is also hospital filling of ambulances where they can come in and then they sub out for the administration that they provided to a patient at the time they drop the patient off. And that's been going on for years.
In my hospitals, we have been providing, we're discontinuing it and moving on, but there was a reconciliation for every dose. Every dose that was given out, there was documentation provided as to who was given. The medication was given to you before the resupply happened. So it was a one-for-one replacement.
EMS may also have additional means by which they restock their equipment through their own physicians.
Okay, so can I call for the vote if we move forward with the committee's recommendations that the board withdraw the old rulemaking and initiate a new rulemaking with the proposed language dated May 25th, 2016. All in favor, raise your hand. Thanks. I think this is going to make a big impact. I'm really glad that we're moving forward with this regulation. Thank you. Item C, discussion and consideration of the Department of Consumer Affairs contract and audit of the DCA diversion program provided by Maximus Health Services. This is attachment 3. The California Business and Profession Code provides that various healthcare licensing boards under the auspices of DCA may establish a program to identify and rehabilitate licensees whose competency might be impaired due to substance abuse or mental illness. The board is one of several DCA boards that have implemented such programs. However, our board's program differs from those of other DCA boards in that it does not divert licensees from discipline. It uses the program as a monitoring program for its participants before, during, and after discipline has been secured. In 2003, DCA began contracting with Maximus Health Services to provide what DCA calls diversion program services. In October 2015, an audit of Maximus was conducted for the contract period from January 1st, 2010 through December 31st, 2014. The report was referenced in the board's 2015 Sunset Report, but never shared with the board specifically. So at the committee meeting, Ms. Harold explained the program's importance and process, and Ms. Sodergren provided information about the board's costs to run the program. I know Ginny and Angie, you guys want to add anything to this?
I don't think so unless the board has questions. I think the intent was to provide the report out there. It was part of our sunset review that we attached as a supplement, and this is just providing closure because we didn't have an opportunity to put it on an agenda prior to this meeting.
Just the one other thing that I'll say is pursuant to the uniform standards, there is a specific standard that does require an audit of a vendor that provides the services. And so this audit was in compliance with the uniform standards as well.
So the average length of time then, Ann, is the participant stay is 3 to 5 years.
Yeah, I mean, it does vary depending on the underlying issues, but generally, yes.
And the audit and the board's program is in compliance with SB 1441. Any questions from the board members? Copy of the audit is in attachment 3. Public comment. Okay, moving on to item D. Discussion and consideration of the FDA's required class-wide safety label changes for opioid pain medications. On March 22nd, the FDA announced required class-wide safety label changes for immediate-release opioid pain medications. Among the changes, the FDA is requiring a new box warning about the serious risks of misuse, abuse, addiction, overdose, and death with these agents. They're also requiring a warning that chronic maternal use of opioids during pregnancy can result in neonatal opioid withdrawal syndrome, which can be life-threatening. Provided in your packet is a sample of how the new black box warning label may appear. The FDA is also requiring several safety labeling changes across all prescription opioid products to include additional information on risks. Copies of the FDA's news release and safety announcement are provided in attachment 4. Any board member comments?
So where do you see this warning when you're getting your medicine?
It'll be, the black box warnings typically on the package insert for the pharmacists. So we anticipate there'll probably be some assessment. The pharmacist will assess the patient, also including counseling.
But it goes in the bag with the pills and everything, so you may or may not look at it if you're a patient.
Well, black box warning is usually to those that dispense and prescribe. It's something that is, the FDA places on the responsibility on the healthcare professional
Oh, so this is something that the dispenser sees?
and the physician.
They can provide it to the patient, but generally, I don't think you see them.
Unless there's a REMS program, which there's been some discussion about that as well, about doing a risk about mitigation strategy on opioids just because of all the issues. I don't think the FDA has gone there yet, but if it comes to that point, sometimes these REMS programs do have patient notification requirements.
Well, how does this fit into the workflow of a pharmacist? So a patient comes to the counter, they got a prescription for hydrocodone. I'm the pharmacist, what do I do? Do I look at this thing, or once every year I look at it, or what?
It depends on, black box warnings are very common. There's a number of drugs that have black box warning. What it is the FDA is saying there's an increased alert when you prescribe or dispense these drugs. Be careful of these things.
Okay. So this is sort of a one-time thing they're supposed to remember.
Yeah, it's kind of a part of the package, the FDA approval change. They're saying this is a part of their approval of that drug. They're modifying the approval somewhat with this warning on there. And they're typically pretty serious. Some organizations do assess formularies and do other actions to ensure that black box warnings are communicated to prescribers and dispensers and nurses. Any other board questions or comments regarding? Otherwise, public comment?
Ken Shell, Sharp Grossmont Hospital Pharmacy Director. I just wanted to clarify with Ramon how, from a workflow process, in the pharmacies that we have an outpatient, we do provide the patient with additional literature, and we will go over those important things, especially if it's a first dispense. The patient, of course, has the option to decline, but in black box warning type situations, we will bring that forward to the patient and review with them, saying you're taking this medication. These are some things above and beyond the usual considerations. It's not always clear that the patient understands it. We try to put it in language that they can understand. We provide them also with supplementary documentation. To your point, goes in the bag. We hope they read it. We know that that doesn't always take place, but on the first dispense, we will do that. As we are processing that first prescription, the black box warning comes up to the pharmacist and it goes on the sheet. So they know each time there's a dispense with a black box warning, they receive it. So it's not like they see it once, or we expect them to recall that this drug has a black box warning. It's that it's given to them to see, and then the expectation we have is they review those things with the patient on the first dispense, because it is serious, and there's liability associated with not telling them that. And if something were to happen and it was the patient said they never said anything to me, now we have a problem. So again, we require that our pharmacists speak to the patient about it. Then the patient actually has to sign that they acknowledge that they received this information. So, and you hate to say you're just covering yourself in that, but you want to make certain that there is some documentation that at least there was a good faith effort made to give the patient that information.
You require that documentation for every black box warning? That the
It-
patient signs off that they acknowledged it?
No, not for the black box warning. It's just that they got the consultation. The software that we have brings it up, but it doesn't say specifically you got black box warning. No, that doesn't do that. We could probably modify our software to do it, but we don't do that at this time.
You're documenting every consultation?
No, by policy, we have to do it unless the patient defers. And so then there's a little slip that says the patient received the documentation, which they sign, and we do keep that, yes. And that's just part of the software we have built out. In fact, in two separate situations, one at Children's where I was director and one here, we had that same type of receipt essentially that came, it was a sticker and we put it in a book. How you track that is anybody's guess, but we did keep track of it. We kept those records for 3 years.
So, Ken, this only apply to this black box warning for the opioids prescriptions right now?
I haven't seen it, but if it were to come up on the sheet, the manufacturer software would bring that up as an
Update you on
upgrade.
all the black box warning on any other drugs that come up later?
Yeah. Yeah, and we do it for all of them. We have to, basically. It's by policy for our organization.
Well, that's
Good
good.
software.
And you put a brochure or something in there for the patients on this?
Yeah, so with each medication that's dispensed, there's a supplementary education document because the manufacturer's insert is in a language that few understand, even
Right,
them, I think.
exactly.
So we actually have a secondary piece that prints out. It says,
Right.
this is your medication. These are some things you consider. And it's done at a level that someone, and I believe it's sixth grade is the kind of the litmus test of understanding that someone who had a sixth grade education can understand. And we do provide that with them with all the other paperwork that they have. But I think to Ramon's point, a lot of people get the bag, they fish in there, they pull out the medication, the bag goes in the dumpster, hopefully recycler, and then they don't have it anymore. But usually the people who are taking medications with black box warning, and this expands it now, they're focused on those medications because sometimes it's imperative that they take it correctly so that they can actually live. With opioids, it's going to be a little bit different because of how they are misused, and people
Right.
don't
That's why I
often
said
want to
that's
carry.
really good.
They don't care as long as they feel good. They're willing to take the risk, but it's still our purview to give them the information. And we also, from a regulatory perspective, have to be cautious about dispensing it to patients who have addiction issues because that puts us at liability as well. So, and the Cures report really helps with that. So we're able to identify those who have less than honorable uses for the drug.
Right.
And then we can refer that back to the physician so they can manage them at the physician level, because once they get to the counter, they've got a legitimate prescription. And it's hard for us to diagnose the patient right there at the counter, whether they're an addict or not. That's not our training and scope. Although if you look at a Cures report and you see they've been to 15 pharmacies over the last week and they've gotten 1,000 tablets of Vicodin and they say, oh, I lost it. Well, we're somewhat suspicious at that point. So again, it's something that with all the technology that's available to us now, we've really been able to close the loop with who gets what and whether it's being used appropriately. It's been Cures has been very helpful. We're kind of the model for the rest of the country. We just had a pharmacy in Texas call us and ask us how did we do it. So we sent them a blind copy of what we provide, but we know that we in our state we provide the best information to the providers and to the patient, at least in my opinion.
This applies to the outpatients that you have. What about the inpatients?
And the inpatients, it's a different story. A lot of times it's difficult to give that to an inpatient because they're not conscious. So we do, again, the nurses, the physicians, and the pharmacists all have awareness of this. When the physician, we have a Cerner as our electronic medical record. So as the physician pulls that up, there will be a flash black box warning to them telling them that this drug has cautionary type activities. And then it goes on the nurse's MAR too, that this is a black box medication. And so when a medication is new to the patient, the nurse is supposed to go over that with them. On discharge, now we have pharmacists involved in the process. We didn't have it as much as we could have, but in the last 6 months, we now have a pharmacist who helps with the discharge of the patient. So they review all the medications that patients have, including those with black box warnings.
And would they have documentation that they sign acknowledging that they received this consultation?
We actually don't have the patient, but the pharmacist who does the discharge counseling actually on a daily basis provides us with who he did and what he said. And so we're using that. And the patient, when they get discharged, they sign, that all these things have been reviewed with you. Again, when you're ready to go home, I'm sure people are just signing papers, not reading what they're signing, which is unfortunate. But we do have a survey that goes out to the patients too, asking them if they have any questions or if something got missed. Did you receive this? And they will say no, and then we have to follow up. We try to follow up with them if that's the case. And do they do HCAP scores for you guys? You guys have? There's a company that does surveys for patients, and it's a standard throughout the country. And so it's very much a litmus test of whether we're doing our job because it compares us to all the hospitals in the country. So,
Right, hospitals usually.
yeah.
Thanks, Ken.
Okay.
Moving on to, any more public comment on this item? Otherwise, we'll move on to item E. On March 15, 2016, the CDC released 12 recommendations for primary care clinicians who are prescribing opioids for chronic pain outside of active cancer treatment, palliative care, and end-of-life care. The recommendations are grouped into 3 areas: determining when to start opioids for chronic pain. The second one is opioid selection, dosage, duration, follow-up, and discontinuation. And 3, assessing risk and harms, addressing harms of opioid use. So the categorization of the recommendations was based on the fact that there's no evidence that shows a long-term benefit of opioids in pain and function versus no opioids for chronic pain, with outcomes at least examined 1 year later. So patients on chronic pain meds, you really don't see the benefit. And extensive evidence shows that the possible harm of opioids, including opioid use disorder, overdose, and motor vehicle injury. And thirdly, extensive evidence suggests some benefits of non-pharmacologic and non-opioid treatment compared with long-term opioid treatment with less harm. And I think we've heard this quite a bit with in terms of our review of drug diversion in the drug abuse committee that we had. The guidance from the CDC is in addition to guidance provided by other agencies on opioid prescribing. As the medical director that was the medical chair, the medical board's executive officer that was here yesterday, Kim Kirchmeier, had informed us in November 2014, the medical board produced its guidelines for prescribing controlled substance for pain. And according to her, the medical board is in the process of comparing the guidelines with those of the CDC. And I think she told us yesterday that they have, and they just feel that they supplement each other. So there's no changes planned for the medical board guidelines. And the medical board guidelines can be found on their website.
Well, the CDC guidelines are different in the level of medication that they consider to be of concern. The medical board standards are basically anything over 90 milligrams morphine equivalent a day is what they call a yellow flag. Anything over 120 is a red flag. The CDC lowered those numbers to 50 and 90. There's a difference there.
And the pharmacies receiving prescriptions for chronic opioid use is just a downstream effect of the prescribing of it. So we're very, we need to work with the medical board in making sure that the prescriptions that are being prescribed are effective and appropriate.
And they're interested in doing that, but the medical board, I think, did have some plans to make the 2 documents closer, so that there isn't 2 conflicting, a federal and a state different version, although many states have different versions than what the CDC put out either, or as well, so.
And Jenny, you can keep us updated as to when that, how that goes, because that's really important, because it impacts us pharmacies.
Right, there's no magic number, of course, but the studies show that when it gets to the death rate, when you get to about 100 milligrams, starts to, the curve sort of slowly is going up until about 100, and then the curve kind of takes off around 100 milligrams a day.
One of the red flags they're planning on putting into cures is to somehow use 100 morphine equivalent dosage units or something. I think it was 100, it might have been 80, I don't remember. But I don't think that particular feature is yet available with the cure system.
It's difficult because it involves calculations. You've actually got to calculate the drug and then what is the morphine equivalent dose and put that in there. So it does involve some assessment.
Yeah, there's some program that's out there that they were looking at using.
State of Washington has a website, a converter.
Yeah,
where
maybe that's what how they
put hydrocodone.
For MED?
Yes. And you put the dosage of the particular drug, and then it converts, and there's your other number.
Right. Any other board questions or comments regarding this item? Public comment? Okay, we'll move on to item F, which is the regulation that we referred to earlier, with this discussion and consideration of a proposal to add statutory authority relating to registration with the Board of Automated Delivery Systems for dispensing of medication. So at the February 2016 board meeting, the board considered a draft proposal to establish a registration requirement for pharmacies that operate automated drug delivery systems. And this is part of the sunset review process. During this meeting, the board discussed creating inventory requirements for the devices and the need to clarify some of the terminology that's used in the draft language. We also heard public comment in which the board was asked to modify the requirements for hospitals that use automated delivery system. So the board asked the staff to modify the language and bring it back to the Enforcement Committee for further discussion. Subsequent to that meeting, staff worked with myself and Ms. Veal to refine the language, and it's provided below. And if you see, it's attachment 6. It'll be the amended language from the June 6th special board meeting. So, and it states, A, for purposes of this section, an automated drug delivery system includes a device as defined in Health and Safety Code 1261.6A1. B, every pharmacy that owns or provides dangerous drugs dispensed through an automated drug delivery system shall provide the board in writing with the location of each device within 30 days of installation of such a device and on an annual basis as part of the license renewal. The pharmacy shall also advise the board in writing within 30 days if the pharmacy discontinues operating an automated drug delivery system. C, every pharmacy that uses such a system may only do so if all the following conditions are satisfied. 1, use of the device is consistent with legal requirements. 2, policy and procedures include appropriate security measures and monitoring of the inventory to prevent thefts and diversion. 3, drug losses from the device are reported to the board as required by law. 4, the pharmacy license is unexpired and not subject to disciplinary conditions. D, the board may prohibit a pharmacy from using a system if it determines that the conditions provided in subdivision C are not satisfied. If such a determination is made, the board shall provide the pharmacy with written notice, including the basis for the determination. The pharmacy may request an office conference to appeal such a decision within 30 days of the written notice. The executive officer or designee may affirm or overturn their prohibition as a result of the office conference. E, a system operated, and this is the section that we changed in response to the hospital concerns, a system operated by a licensed hospital as defined in section 4029 for doses administered in a facility operated under a consolidated license under Health and Safety Code section 1250.8 shall be exempt from the registration requirements of subdivision B. And what that means is if I'm operating an automated device on my hospital grounds, which is what the consolidated hospital license is, I'm not required to separately register that because it's considered on my grounds or in my house, essentially. It's only when it's stored off-site, when it leaves that consolidated hospital license, is when it's considered an off-site storage. So at the committee meeting, the committee reviewed and discussed subdivision C and D of the proposed regulation. Mr. Lippy inquired about, and this was in the original language, a 75-mile radius. It just seemed arbitrary. Sometimes it could be 80 miles, and it's kind of an arbitrary number that we had before. So we actually removed that. When the committee began leading towards eliminating the distance requirement, then the distinction moved as to whether the board should specifically limit the locations to within California. So can we actually ship over across state lines? And whether pharmacies could provide drugs to other states without obtaining a license in the other state. Supervising Inspector Dang clarified that even 2 pharmacies may be close in proximity, so let's say they're near the border, they could not ship across state lines without obtaining a license in the other state. So that was clarified for us. So the committee heard public comment in support of eliminating the 75-mile radius limit. So the committee recommendations are, 1, recommend that the board eliminate the 75-mile radius and remove subdivision C5 from the proposed regulation. 2, recommend that the board amend, and Ms. Friedman actually suggested clarifying good standing, and that's written in subdivision C4 of the proposed language. And actually, that's in there now. I think we have unexpired and not subject to disciplinary conditions. Do we need to change that, Laura?
You know what? I think this came out in a different version. I'm not sure if I caught it at this meeting, but you have within your statutory definitions a definition of good standing. So I withdraw my prior comments.
Okay.
I want to say it's 4103. Does that sound right?
I think we have in good standing
and
what we provided to the bill. I think that's what went into the bill.
Oh, okay.
It is, okay. Great. And the other committee recommendation is to recommend that the board amend subdivision C4 of the proposed regulation, to replace good standing with unexpired and not subject to any disciplinary conditions. Committee recommendation, recommend that the board amend subdivision E of the proposed regulation to read, a system used in a licensed hospital for doses administered in the hospital is exempt from the registration requirement in subdivision B. The committee made a motion to forward the entire amended language to the board for review and approval. Ms. Harold warned that the board sunset bill would have to go into the assembly without the registration provision if the board chose to work through and include the inventory language. So did we submit it?
Yeah, because we had an emergency meeting, if you'll remember,
Yes.
specifically to address this.
Yes, that's right, okay. So the committee recommendation is to recommend that the board remove the underscored portion of subdivision C2 of the proposed regulation and forward the final revised proposal to the board. At the June 8th special board meeting, the board reviewed the committee's amended language and voted further to revise section E to clarify the definition of a licensed hospital. And a copy of the committee's proposed language and the board's final language are provided in attachment 6. So since we already voted, we don't need to do anything at this meeting.
This was a little awkward in terms of how this fell into the packet, but
Yeah. Any board questions? Public comment? Okay, moving on to item G. Consideration of a proposal to conduct inspections of all pharmacies every 4 years. That's attachment 7. So the board's charged to regulate the pharmacy profession. I mean, we've talked about this before, having routine inspections of licensed facilities to confirm adherence or identify failures, so that the board inspectors are inspecting pharmacies and educating on a routine basis rather than just coming in for cause. For a number of years, the board's policy has sought to inspect all facilities every 3 to 4 years, and the board has been unable to complete these routine inspections with any regularity, and in recent years has had to substantially reduce such inspection because of the investigation of complaints and the focus on sterile compounding inspections. While thousands of inspections are completed, inspections generally occur as part of the investigation process. So included in your packet is a volume of the number of inspections and inspection types from fiscal year 11-12 through fiscal year 14-15 by visit type. I don't know, Jenny, do you want to go over that? And
well, right now, we're at the front end of the first of the 4 years, and so, I don't know, I think that at this point, we're stepping into this thing slowly. We have to hire someone to literally track these inspections in a manner we're not currently doing. And so that process is already underway. The goal is to make sure that some of the pharmacies where we don't have complaints do in fact get inspected. And that even though we're going to be inspecting the sterile compounding pharmacies every year, and even though we will continue to investigate complaints that will take us into certain pharmacies, and we've got some pharmacies on probations, or we've got individuals working in pharmacies that are on probation, they get inspected quarterly, that we will back out and identify those pharmacies that haven't been inspected in the last 4 years and start targeting those specifically for inspections. We intend to allow all board inspectors to do some of these inspections, but the focus will be on the compliance team, which is about we've got three compliance teams, so 3 of 8. So it's a chunk of our inspectors are going to be doing these inspections long-term, but it won't be solely them.
So
at the,
while they investigate on certain cases, they could do inspection at the same time, right?
That will be counted as one
That's so-
inspection.
yeah.
Right, yeah, so we'll get in some that way.
Yeah.
But the goal is also, though, to just walk in and say, hi,
Right.
Albert, we're here to inspect your pharmacy. There's no
Which they
complaint.
did.
Right now, when they see us walk in, they know they're under investigation, even though we frequently will not tell them why we're there.
so at the February board meeting, the board referred the matter back to the enforcement committee for discussion. So at our committee meeting, we discussed this, the fact that there is annual sterile compounding inspection. So hospitals essentially are being inspected every year, as Ginny has just stated. And in terms of the board additional inspections that each board inspector would need to do, The board expects each inspector will have to complete 12 additional inspections per year if current statistics remain constant. So that's like one inspection a month
Yeah,
that they would have to do in order to accomplish this,
right.
which we believe is doable.
We believe this is doable. The goal is, right now, we're in the process of finalizing the last few vacancies, filling those. And once we have those, there'll be a focus on training, and one of the things we do when we train, focus on compliance inspections. So we'll get to them, but like I said, it'll be really year 2 and 3 where we can really determine how close we're going to be and what specifically is going to be required to bring this in, so that all pharmacies will be inspected every 4 years.
Yeah, I would like to see it doing those inspection, do a little more education also,
That's the purpose. We're finding certain violations pretty routinely when we walk in. People aren't signed up to the subscriber alert system. People aren't doing their self-assessment, and that is a real frequent one. So part of that is educating and getting the pharmacy back into compliance with basic pharmacy law. Doesn't mean they won't get a violation notice too, but the intent is to really just get them into compliance as much as
Well,
possible.
you give them the education on the first try, and then you come back the following year, the next 4 years, you're consistent